welcome back. Today, we'll start to learn about different morphological patterns of acute inflammation. Acute inflammation is rapid in onset with short duration. Exudation is the prominent pathological change of most forms of acute inflammation. According to the main components of exudate, acute inflammation is mainly classified as serous, fibrinous, suppurative, and hemorrhagic inflammation. Some inflammatory diseases may manifest as acute ulcerative inflammation, such as epidemic encephalitis B, or proliferative inflammation, such as typhoid fever. In this session, we'll discuss acute serous inflammation and fibrinous inflammation. After this session, you should know what is serous or fibrinous inflammation, what are the main etiological factors, and which are the main affected sites, what are the pathological features, and what are the outcomes. Let's start with serous inflammation. I have shown you this picture in my first session. The affected skin is red, swollen, and has multiple blisters. Microscopically, these blisters are full of a fluid called serous exudate. Actually, the formation of this lesion is due to serous inflammation caused by herpes zoster virus. Serous inflammation is the mildest form of acute inflammation. It is characterized by the exudation of a watery, relatively protein-poor and cell-poor fluid, derived either from the plasma or from the secretions of mesenchymal cells lining a serosal surface. The main etiological factors of serous inflammation include hypersensitivity reactions, bacterial and viral tissue infections, and physical and chemical tissue injuries. Serous inflammation is commonly seen in mucosa, serosa, loose collective tissue, and skin. In the mucosa, serous inflammation causes hyperemia and edema. For example, acute serous mucosal inflammation of the larynx leads to acute laryngeal edema with risk of asphyxia. Early in the common cold, massive serous exudate of the nasal mucosa produces watery discharge. In serosal surfaces, such as pleura, pericardium, peritoneum, the serous exudate may accumulate in the cavity, resulting in hydrops. Serous inflammation of loose collective tissue may cause tissue edema. In the skin, the typical manifestation is blistering caused by a burn or viral infection. The formation of a skin blister is morphologically due to the accumulation of a serous exudate, either within or beneath the epidermis of the skin. Resolution is the outcome of most serous inflammation, in which the fluid is reabsorbed. However, excessive exudate may cause severe consequences. For example, laryngeal edema would cause airway narrowing, which leads to dyspnea, even asphyxia. Massive serous fluid accumulating in the pericardial or pleural cavity would influence the functions of the heart or lung, respectively. Next, we'll discuss fibrinous inflammation. Look at this case. A 25-year-old man has developed high fever, chest pain, cough, and difficulty breathing over the past several days. A chest radiograph shows consolidation in the entire right lower lobe. Laboratory test of the sputum reveals a predominance of Streptococcus pneumoniae. The clinical diagnosis is pneumonia. What about the microscopic appearance of the affected lung? This picture shows the representative microscopic appearance of lung tissue with this pneumonia. These alveolar lumens are filled with massive eosinophilic thread-like cross-linked substances. What are these substances? They are fibrins. This pneumonia is marked by fibrinous exudation. The pathological diagnosis is lobar pneumonia, a fibrinous inflammation of lung. It usually involves an entire pulmonary lobe, resulting in lobar consolidation. The inflammation may spread to the pleura and cause fibrinous pleuritis, so the patient has chest pain. Streptococcus pneumoniae infection is the principal etiological factor of lobar pneumonia. What is fibrinous inflammation? It is an acute inflammation marked by exudation of fibrinogen that leaks into the tissue and then is converted to fibrin. Compared with serous inflammation, fibrinous inflammation occurs in conditions in which the vascular injury is more severe, resulting in greater vascular permeability that allows large molecules such as fibrinogen to pass through the blood vessel wall. The main etiological factors include infection, poison, and other factors. For example, infection with Streptococcus pneumoniae and Shigella dysentery, mercury poisoning, uremia, or rheumatic disorders. Look at this picture. Microscopically, the accumulated extravascular fibrin is eosinophilic, thread-like, and cross-linked. Fibrinous exudate is often mixed with neutrophils and necrotic tissue debris. Fibrinous inflammation occurs chiefly in serosa, mucosa, and lung. In the serosa, we have examples such as fibrinous pericarditis, pleuritis, and peritonitis. In the mucosa, we have acute bacillary dysentery. And in the lung, lobar pneumonia, which I have talked about just now. Next, I will introduce fibrinous inflammation occurring in the serosa and mucosa. First, let's go through fibrinous inflammation occurring in the serosa. This is our heart. How would you describe its gross appearance? We can see that the epicardium has a wide area of villous deposits on it, producing a cotton-like appearance. What are these villous deposits? Let's look under the microscope. We can see massive eosinophilic meshwork of fibrin exudate overlying the epicardial surface. Therefore, these villous deposits are mainly fibrin strands. The pathological diagnosis is fibrinous pericarditis, also called hairy heart. We may hear a friction rub over the front left chest with a stethoscope. The formation of a friction rub and the cotton-like appearance of heart are due to the rubbing of fibrin strands on the epicardial and pericardial surfaces as the heart beats. The common etiological factors include uremia and rheumatic disorders. Let's move on to fibrinous inflammation occurring in the mucosa. In such inflammation, the fibrinous exudation process is usually preceded by superficial necrosis. Here, I use acute bacillary dysentery as an example. Acute bacillary dysentery is caused by Shigella dysentery and usually occurs in the sigmoid colon and rectum. This colon sample with bacillary dysentery shows patchy and dirty gray membrane-like substances scattered on the mucosal surface of the colon. What are the substances of this membrane-like structure? Let's see their microscopic appearance. The colonic mucosa has superficial necrosis and is covered by a layer of membrane-like substance. The high-power view of this substance reveals massive meshwork of fibrin exudate mixed with neutrophils. Hence, the membrane-like substance is a pseudomembrane formed by coagulation of fibrin, neutrophils, necrotic mucosal debris, and bacteria. Fibrinous exudate is the principal component. Therefore, acute bacillary dysentery is a type of pseudomembranous colitis. Shigella organisms invade locally and damage the intestinal mucosa and cause massive fibrinous exudation, leading to pseudomembranous formation. If these pseudomembranes come off, superficial map-like ulcers appear on the mucosa. Affected patients have crampy abdominal pain, diarrhea with mucopurulent bloody stool. Here I introduce the concept of pseudomembranous inflammation. It refers to a fibrinous inflammation occurring in the mucosa, in which extensive fibrinous exudate forms a layer of pseudomembrane covering the affected mucosa. What are the outcomes of fibrinous exudate? If fibrin exudate is not excessive, it may be completely degraded by proteolytic enzymes, which are released by neutrophils. Then the dissolved exudate would be removed through the lymphatic system or by macrophages, resulting in restoration of normal tissue structure. However, if fibrin exudate is abundant, or fibrin exudation is accompanied by insufficient neutrophil exudation, massive fibrin exudates may not be completely dissolved and removed, and therefore are oxidized by granulation tissue. Oxidation may result in fibrous thickening or even permanent fibrous adhesions of the serosa. For example, oxidation of fibrinous pericarditis would produce constrictive pericarditis, which manifests as severe fibrous adhesions between the visceral and parietal layers of the pericardium. In lobar pneumonia, oxidation of intra-alveolar fibrinous exudate results in oxidizing pneumonia. This is the histological appearance of oxidizing pneumonia. The alveolar lumens are filled with granulation tissue, grossly producing a flesh-like pulmonary cut surface. Now, let's make a summary. Serous inflammation is characterized by exudation of watery, protein-poor serous fluid, and usually occurs in mucosa, serosa, loose connective tissue, and skin. The outcome is resolution in most cases. Fibrinous inflammation produces fibrin-rich exudate, and usually occurs in serosa, mucosa, and lung, such as fibrinous pericarditis, acute bacillary dysentery, and lobar pneumonia. The outcomes include resolution and oxidation. That's all for now. Here are the references and acknowledgement. Next time, we'll talk about suppurative inflammation. See you then.